Good afternoon. My name is Ron Burakoff, and I'm the professor and chair of the Department of Dental Medicine at the Hofstra North Shore-LIJ School of Medicine. And today's webinar is going to be on the prevention of dental disease, and especially the prevention of dental caries. As I was preparing for this webinar last week, I saw an interesting article that came out with from the proceedings of the National Academy of Science. And the lead was tooth decay first ravaged human society 15,000 years ago. It was this was found in a Moroccan cave known as the Grotto de Pigeons. These people, or these humans that inhabited this cave, had a pretty good life. They had fine living quarters, they had a close-knit community, and had plenty to eat. But unfortunately, they had a high caries rate, even though they were hunter-gatherers. It was always thought as conventional wisdom that hunter-gatherers were kind of immune from dental decay, and it only took people that were raised after the age of agriculture or raising carbohydrates that we had a high caries rate. Previously, hunter-gatherers had a caries rate of 14%, but the people from the Cave of Pigeons had a caries rate of 94%. Well, what happened was they took a look at the food that they were actually eating, as it turned out that they were eating a sugary acorn type of material, which increased the likelihood of them having cavities. Unfortunately, they were able to get this high rate of cavities without having the luxury of enjoying the cupcakes and the soda that our contemporaries have. With the advent of farming about 10,000 years ago, the caries rate jumped up to 14%. So today I'm going to go over one of the most common diseases of man, dental caries, and talk about ways that we can prevent it and talk about the extent of the problem in New York State. So dental decay is multifactorial. The multifactorial means that, of course, there are many causes, which gives us many opportunities to try to reduce the amount of decay. One of the things we can do is we can try to increase the resistance of the host. And this is done by increasing the hardness of the tooth surface. And many of you know about the role of fluoride, and we'll talk about that later, but fluoride actually works in two ways. It works systemically by ingesting it, and the tooth surface becomes harder, and also fluoride can be obtained by providing gels or varnishes or local or rinses. Dental decay is also diet dependent. It requires that there are carbohydrates and sugars that the bacteria that is the method that the bacteria produces acid which dissolves the tooth surfaces, and the bacteria have to be fed, so it's diet dependent. It's also salivary mediated disease, and this is because if the saliva actually works to reduce the amount of decay, but in individuals that might be taking medications or have had radiation exposure or have had changed the quantity and quality of the saliva, we have an increase in dental decay. And dental decay is a chronic disease, and it's cumulative, and it's really it's based on an infection. The bacteria that's in the mouth that's part of the biofilm causes the tooth decay. We all know what the risk factors for decay is. It's really diets high in sugar, and also we talked about the flow and composition of the saliva, and we talked about the bacterial flora of the mouth. The bacteria that's most responsible for dental decay is Streptococcus mutans, which is the most predominant one. Most childhood diseases, most common childhood, dental decay is the most common childhood disease. 80% of all children experience it by high school graduation, and it's most severe in 25% of the children. When we talk about most severe, some children have all of their teeth affected in a condition called early childhood caries. In New York State, about 3.5 million children experience tooth decay by high school graduation. Now, what happens if we leave caries untreated? It becomes a significant oral and systemic problem. Number one, you could have impaired physical problems. If you can't, if your teeth are not available, or if you lose teeth or you have pain in your teeth, you might not be able to taking the appropriate nutrients, and you can actually have physical problems. You can have difficulty eating. It's hard to eat when you don't have teeth, and altered speech, and this affects the child's performance in school. And also, tooth losses could be painful, and it also could be part of an infection. So children with decay could have difficulty in concentration. They could have difficulty in learning. They have increased school days that they miss. They have lowered self-esteem, and this results in a reduced capacity to socialize. Now, what about how bad is the problem? Well, the problem is really endemic in the United States. U.S. children lose more than 51 million school hours annually because of dentally related illnesses, and the cost is significant. It can be as much as 15% of all the health care expenditures among school-age children. In New York, 4,800 children under 6 are treated at ambulatory surgery facilities. So these are children that cannot sit in a dental chair and have to be taken into the operating room, placed under general anesthesia, and having dental procedures done. And the cost per visit is $6,293 and rising. So as you can see, this can add up pretty quickly. So let's talk about the extent of the problem here in the United States and in New York State. In the U.S., 1 out of 5 children under the age of 18 go without dental care. Most low economic children nationally lack basic dental care. In New York State, almost 1 million children under 18 go without care. Even with Medicaid, which is the program that provides for payment for services for children with dental disease, only 1/3 of the children receive any dental care. So even though they have the funds to obtain dental care, they go without. So dental caries becomes a selective problem for children that are disadvantaged. Too few children have access to preventive measures. Too few dentists are willing to treat Medicaid-enrolled children. Dentists complain that the appointment that individuals on Medicaid may not be able to come for their appointments. Their no-show rates are higher, and dentists that are able to fill their chairs with individuals that are paying full fare are less likely to accept Medicaid, which is a reduced payment schedule. And in some communities, there are not enough dentists to provide any care to these children. So let's talk about what are some of the prevention strategies to help alleviate this problem. On an individual basis, certainly toothbrushing is extremely important. Toothbrushing, the biofilm that causes dental decay organizes within 24 to 48 hours. So if you could keep the biofilm clean by using toothpaste and toothbrush, you could actually eliminate the items, or you can eliminate the bacteria that causes decay. We could also encourage good oral habits, and these include appropriate feeding, snacking habits, and healthy dietary practices. It's not the amount of sugar that an individual eats or takes in that's as important as the frequency. So if you have if you can limit the sugar intake to selective times during the day, and try to couple that with brushing and cleaning, the rate of decay decreases. Another big area to talk about is anticipatory guidance. When we have programs where we talk to pregnant women about how to protect their children, and in reality, really, it starts early, because as we talked, dental caries is an infectious disease caused by a bacteria. This bacteria is really transferred from mothers and caregivers to the children. Some of the cultural habits of tasting the food before you give it to the child and transferring from the mom to the child actually is a way that you seed the bacteria that helps cause decay. So we have to talk about issues with and giving anticipatory guidance to parents and to moms. And the other thing is that, when should a child be seen by a dentist? The age that a child should be seen by the dentist seems to be moving up each year. But now there's pretty much of a consensus that a child should be seen by a dentist as soon as the first tooth appears or by age 1. And of course we could encourage regular dental visits. I want to just take a look at this graph, and it's entitled "The Percent of Third Grade Children with Caries Experience in Upstate New York in 2002 to 4 and 2009 to 11." I think what's important is that we've divided the issue up into 3 categories. The first is all children, the second is high-income children, and the third is low-income children. One of the interesting things that of the good news is that if you look from 2002 to 2009, all 3 categories are decreasing. However, it's a selective decrease. The children with high income are doing much better than children with low income. This chart looks at the percent of third grade children with untreated decay, and the message is actually starting to repeat itself. We've also divided this up between all children, high-income children, and low-income children. We looked at 2002 to 4 and 2009 to 11. And from 2002 to 4 to 2009 to 11, the amount of untreated decay is decreasing for everyone, but unfortunately, again, the low-income children are not doing as well as the high-income children. So these data trends are pretty remarkable. Dental caries is decreasing, which is great. The decrease, unfortunately, is observed primarily in high-income children. And unfortunately, again, disparities in oral health care have widened over time. Low-income have a higher prevalence of caries, and they have a higher prevalence of untreated disease. And they also have a lower utilization of dental services. Despite the fact that Medicaid allows and can, in fact, level the playing field, many children eligible do not receive routine dental care. Children between 5 and 9 with 50.2% utilization of dental services met the Healthy People 20,020 target of 49%. Children between 10 and 14, and this is in New York State, barely missed the Healthy People target of 49%. They came close with 48.6%. We also have some, looking at the 2020 goals for healthy people, we want to reduce to 30% the proportion of children aged 3 to 5 with dental caries in their primary teeth. We want to reduce to 49.9% the proportion of children aged 6 to 9 with dental care both in their primary and permanent teeth, and to reduce to 25.9% the proportion of children aged 6 with untreated dental decay in both primary and permanent teeth. We also want to increase to 49% the proportion of children and adolescents who use the oral health care system in the last 12 months, and increase to 29.4% low-income children and adolescents who receive preventive services in the last 12 months. And an increase to 28.1% children who received at least one sealant and a permanent first molar. And lastly is to increase the proportion of the U.S. population served by community water supplies with optimally fluoridated water to 76.6%. Here in New York, we have a very interesting situation. On Long Island, it's the lowest concentration of people that are served by community water supplies with fluoride. Fluoridation is considered widely as the most effective public health measure, and unfortunately many of the children in our community don't take advantage of this because of the fact that the water supplies are not fluoridated. In New York State, by the year 2013, we would like to reduce the prevalence of tooth decay in third graders to no more than 42%. Just to graphically point out the percentage of Medicaid-eligible children with dental visits. What's happening is, the good news is that it's going up and we're going in the right direction. And if you look at these two graphs, one is for 5 to 9-year-olds, and the other is for 10 to 14-year-olds. So the direction is in the right direction, and hopefully we can continue that way. I also want to take a look at the percentage of Medicaid eligible people, children with preventive dental services in New York in 2005 to 9. If you follow the graph again, we're going in the right direction. There is some interesting data to be mined here, is that various age children are doing better, and we're not exactly sure exactly why, but if you notice, the older children are have less visits than the younger children, so I suspect that we can count on the parents to help them bring them to the dentist. Another major component of the prevention strategy for dental decay is the use of dental sealants. Dental sealants are placing a plastic-like material on the chewing surfaces of the teeth to prevent biofilm and bacteria to form in the cracks and crevices of the teeth, and prevents dental decay. It's very effective for preventing dental decay. But placing sealants, it has to be done by a professional, so it's something that requires a professional intervention. But again, in 2002 to from 2002 to 2009, we've increased the number of children that have benefited from fluorides from 38% to 42%. And again, we see that old bugaboo where disadvantaged children are unable to take advantage of the sealants as much as higher income individuals. So what are some of the goals for prevention for our children? We would like to have 29.4% of our children and adults to have as preventive services yearly. School-age children did exceed this goal this year, and in 15 to 19-year-old children met this goal for the first time in the year 2000. The percentage of children with sealants in one or more permanent molar has increased, but is still below the maternal and child block grant target of 50%. Let's kind of review some of the interventional strategies that we can use for the prevention of dental decay. And remember that we're talking about dental decay or caries or cavities, which is one of the major diseases that that dentists take care of. The other one is periodontal disease, but we're just going to talk about talking about dental decay today. So the first thing and the most effective one is fluoridation and supplemental fluoride. As I talked about, fluoridation is adjusting community water supplies to the appropriate level so that there's a systemic intake of fluoride, and that results in a hardening of the surface of the enamel and decreases the ability of, or increases the ability of the individual to fight off dental decay. In areas where we don't have fluoridated water, we can also use supplemental fluoride. So this is either ingesting fluoride with tablets or liquids, or in fact placing topical fluoride on the teeth. The next available intervention strategy is dental sealants. Again, that's placing the plastic-like material on the tooth surface, which prevents the bacteria from getting in contact with the tooth surface, and therefore not having, and therefore preventing dental decay to begin. We also have in New York State 58 school-based programs, and these are a variety of programs, either with the supervised ingestion of fluoride, or fluoridating the water supply of the school, or having fluoride application programs by professional individuals taking place at the schools. Another intervention strategy in New York State which is used is requiring children to receive a dental health certificate. This is this ensures that the child is encouraged to get, or it encourages the family to have the child see a dentist before starting school. The other issue that we talked about was this anticipatory guidance and risk assessment. There's a condition known, as we talked about earlier, of early childhood caries, where 1, 2, 3, 4, and 5, 2 to 6 year olds have rampant caries in all of the teeth or many of the teeth in their mouth, and require a situation where they have to be taken to the operating room to complete their dental treatment, because it's very difficult to ask a 2 or 3 year old child to sit in a dental chair and have their dental caries taken care of. So we talk about anticipatory guidance. That's talking to the parents and young moms and trying to help them on food selection and treating what to look for. We also have a new vehicle for placing fluorides on teeth, and this is a fluoride varnish. Previously, there were what was used pretty much around the country were fluoride gels. You would go to the dentist and you would have your teeth, the child would have their teeth cleaned, and a gel was placed on the teeth in a kind of a carrier, and the fluoride was put on professionally. Now there's something called fluoride varnish, which is a resin embedded with fluoride that can be placed by dentists, dental assistants. It's actually now being placed by physicians and nurse practitioners. The most important thing about using fluoride varnishes and having physicians and other level individuals place the material is that they're encouraged to do this because they're getting reimbursed. So now all of a sudden physicians and nurse practitioners that work in pediatric offices can help in the fight against dental decay. And as I mentioned before, is having earlier visits to the dentist. Conventional wisdom was either to bring them by 2, 3, or 4. Now it's pretty much, as I pointed out earlier, a consensus that either by the first tooth or by age 1. What can we do for our preschool children? And of course, again, it's this anticipatory guidance, is talking to the family, talking about diet, talking about oral hygiene, talking about toothbrush, talking about, encouraging the parents to get involved in assuring that the individual child has an opportunity to fight dental decay. The other thing is that we have a risk assessment situation. Some children, for whatever reason, have higher likelihood of having dental decay. Some of the individuals that have a higher risk assessment happen to be, as we pointed out several times, individuals of low socioeconomic means, individuals that don't have access to dental visits, individuals that have other medical comorbidities that may in fact change the nature and the consistency of the saliva, or have an effect on their eating habits. And these high-risk individuals should be identified early, and all of the preventive components or all of the preventive therapies that we have should be used for these children as soon as possible. So I also talked about the fluoride varnish applications. I think it's very important that we understand that fluoride varnish is used by dental professionals, and it's now also be used by physicians and other individuals in the pediatrician's office. The dental varnish is a very effective methodology of applying fluoride to the teeth, and well tolerated by the child. So how does a state get together to try to protect the public health problem that confronts their children? And I think that what New York State is really kind of a model state as far as what they've done and what they're doing. And one of the first things it starts is really periodic assessment to monitor progress. I showed earlier some graphs about the incidence of dental decay over time for children and young children by age. Well, the bottom line is, if we don't, as public health professionals, monitor monitor and count what we're doing, it's very difficult to find out or evaluate what methodologies work first. So we have to periodically monitor what the rate of decay is. And this is unfortunately an expensive activity, but it requires us to take a sampling of the population and going out and sort of measuring out how successful we are. One of the things that we point with, that Medicaid funds are generally used to pay for dental services. And as I pointed out before, that fluoridating community water supplies is the most effective and cost-effective preventive measure that we have. So in New York State, an effort has been to take some of the funds that were originally indicated to be for services, are trying to move those over to the most effective means for reducing dental decay, and that's water fluoridation. We also want to expand the school-based sealant programs. So these are designed to focus on children that have been denied access for dental care, and where children are available in schools to bring the professionals into the school and apply the sealants right in the school. And the other thing, of course, is to improve health literacy, to in fact inform and educate the population of the fact that in fact dental decay is a preventable disease, and that that there are interventions that can be done to increase the effectiveness of the battle against dental decay. The other issue, interesting issue, and what's happened with the new Obamacare is that dental care for children has been included in qualified plans. This is a very important aspect, is that it just increases the likelihood of our lower income individuals and all children to receive dental care if it's part of the insurance package. So we're hoping that the new health insurance programs that are coming out will in fact have qualified dental plans, including dental care for children. And the other issue is really changing what insurance companies cover. So if you reimburse someone for doing something, there's a higher likelihood that's going to happen. So if we can get anticipatory guidance as a benefit, and the use of fluoride varnish in managed care programs, that would also increase the likelihood of providing care to the population. So what can be done? What are more things that we can do to limit dental decay? I mentioned earlier, diet modifications. We'd like to, as Mayor Bloomberg tried to do in New York City, is to reduce sports drinks, and he was looking at for the obesity issue. But the reality is that it has a high impact on dental decay. We also want to reduce candy and other high sugar and low nutrient foods, and we want to try to promote and use evidence-based preventive services in oral health counseling. So this issue that when moms are tasting the food of their child before they're giving them on a pretty good reason, is they don't want to give the kid hot food, that you want to make sure the temperature is moderated. But unfortunately, this is a vehicle for transmitting the strep mutans that we talked about that can inoculate the young child and allow for dental decay to occur. So another issue that's in New York State is to increase the capacity, the diversity, and the flexibility of the workforce to meet the needs of all New Yorkers. There are a couple of programs that are actually starting. One is going to allow dental hygienists that work in Article 28 facilities to enter into a compact with a supervising dentist to provide preventive services when the dentist is not on the premises. This will really allow some flexibility into some of our Article 28 facilities and increase the likelihood of preventive dental services being administered. The other thing is the training and the developing of mid-level practitioners to provide dental care and some treatment care. In New York State, we haven't made much progress at to this point in time, but this requires a commitment from the government to fund programs to create a new level of dental provider, much like the nurse practitioners and the PAs that have expanded, or mid-level providers that can deliver more dental preventive services. Increase the number of communities with water fluoridation or appropriate fluoride programs. I can't repeat it often enough that fluoridation of community water supplies, or the ingestion of fluoride, or changing the physical structure of the tooth, is the most effective means of decreasing dental decay. And in a collaborative effort, we would like to increase access to oral health education, information, and materials. New York State publishes lots of materials that are sent to the schools and to the teachers to be part of the science curriculum. But in kind of coming to a conclusion here, what are our major challenges? And frankly, I can't repeat it enough, is that the fluoridation of the public water system, despite scientific evidence demonstrating its effectiveness in decreasing dental decay, may spur greater activity by anti-fluoridations to block efforts. So it's kind of a problem here, is that when we advocate for fluoride in the water as public health professionals and dental professionals in order to try to decrease the amount of dental decay, we sometimes stimulate the anti-fluoridationists who view it as an invasion on their personal privacy, and two, some feel that, but not scientifically supported, that fluoride is a poisonous agent that's being placed into our bodies by the government. So we have to tread water very gently in deciding how active we proceed when we develop fluoride prevention programs for communities. We also have to look at a new way of getting children into the dental office. Despite of all of our activities of trying to increase utilization amongst children, we really haven't done a great job. And that's the end of my presentation, but I have a bunch of questions that we have here. Seem to be pouring in. Let's see what we can do here. Is there any data for the why regarding lack of dental visits for patients with Medicaid? Are intervention are the interventions data-driven or simply assumptions? Well, I mean, there are many reasons why there are a lack of dental visits to patients with Medicaid. Number one is that there are, despite the fact that people have insurance, there are very few dentists that provide and accept Medicaid in some parts of the state. So the bottom line is, even though we have Medicaid, there's not a provider that will in fact take the Medicaid. The next question: why is it so difficult to reach the 15 to 19-year-olds? First time meeting goal was in 2002. Well, I'm not sure of the answer, but having raised a couple of 15 to 19-year-olds, they don't seem to do what parents ask them to do. So I think that this might be a social issue rather than anything else. What is the best source for the latest data regarding dental caries? Well, the National Institutes of Health supports monitoring activity throughout the country. I think the CDC publishes reports, and frankly, if you just take a little dip into the internet, you can find a lot of new data regarding dental caries. Is there a danger of having too much fluoride? Yes, there is. So what are the results of too much fluoride? It's a condition called mottling, or teeth mottling, and it's kind of another one of these double-edged swords. If you have too much fluoride in the water or too much fluoride consumption, the teeth become mottled, and this could be a brownish tinge. These teeth are more resistant to dental decay, but they're sometimes unesthetic. And also, the other issue is that fluoride, if taken in large amounts, is a toxic substance. So you have to monitor what kind of monitor when you fluoride a community water supply. You also have to monitor that it's being done correctly. Okay. So here's the someone asked the question: my thoughts on water bottles, filtered water, and fluoride of public water. Well, as I pointed out before, I'm a strong advocate on community water supplies. one of the things that's happened in community water supply is that they've lowered the recommendation of how much fluoride should be placed in community water supplies from 1 part per million to like 0.7 parts per million. And part of the reason is that, as you pointed out in your question here, is that there are other extraneous sources of fluoride that a child gets. Sometimes in water bottles bottled water may have fluoride. Some of the apple juice may have fluoride, and that's why they have over time reduced the amount of fluoride recommended for community water supplies. Okay, where can teachers find more information about the school-based programs and funding? I'm going to refer you to the New York State Department of Dental Health. It's led by a colleague of mine, Jay Kumar, and we can. That's also accessible on the internet for a number. Does fluoride affect adult teeth? Yes, it does. It also systemically, it doesn't change. If you take in systemically, it doesn't change the tooth. But however, if it's done topically or applied in varnish, it does change the resistance of caries. Dental varnish is indicated for individuals, older individuals that have exposed root surfaces and can be treated topically by fluoride. Dental varnish is also good for individuals that have medical comorbidities, can't brush their teeth, they have difficulty with oral hygiene, and they use varnish to place fluoride on the topical surfaces. So I have a couple more questions here, and one is, why is dental caries a public health problem? Well, it's a public health problem, one, because it's extensive. It has a large, can be a large morbidity involved with dental caries. It could affect development. It could affect how people interact. And the other reason why it's a public health problem is that we can use public health strategies and to intervene to reduce dental decay. The next question is, are we winning the battle against dental caries? And the answer is that we're winning the battle selectively. Wealthier people in our community have shown remarkable decreases in dental decay, for children especially, and those individuals of lower socioeconomic have had some success, but the disparities are still increasing between their higher income cohorts. So if you have any questions about the School of Public Health, Public Health program here at Hofstra, I invite you to speak to Corinne Kiriakou. The telephone and the contact information is on your screen, and I want to thank you for your attention.